Right. Let's go over a scenario where there is hallucination or are hallucinations involved. Let's say the client is presenting with some form of hallucinations. As we know, the first thing that we need to ask ourselves is there a substance involved? So that's the first thing that we do. If we answer yes to this, then we're moving over to the right side of this map, where the next question usually is, in this case, is the person becoming disoriented? Are they kind of going in and out of being aware of their surroundings, kind of person, place, time, maybe some cognitive issues, kind of memory loss, and again, kind of disorientation. If that's the state, typically what that's referring to, if they're kind of in and out of attention, there's some cognitive issues. This is also usually a very acute onset within hours or kind of days. If that's the case, typically, if we're answering yes to that as well, we're actually talking about a state of delirium, which we spoke about in class a little bit in the office hours, where delirium really is an acute onset. There's in and out of awareness, there's cognitive, there's some learning and memory type of situations going on, but it is kind of in the moment acute. In that case, that's actually what they would term then a substance induced delirium. In this instance, we're not associating that with hallucinations. We're saying that the first step is we understand that there's a substance involved. We move over and we ask ourselves, is this person kind of really disoriented, going in and out of awareness? If that's the case, the DSM and this DSM map has us call it substance intoxication delirium or withdrawal delirium. Now, let's say that they're not going in and out of awareness, they're not necessarily disoriented or having kind of this cognitive issues. Let's say they are still having hallucinations though, and we know there's a substance involved. Then we follow this path down here to where we ask ourselves, are the hallucinations the predominant issue, and that they need to be addressed? And if that's the case, then we'll continue over here. And typically, if those hallucinations are going on and that's the predominant issue, then we do diagnose it as a substance medication-induced psychotic disorder. And that's what the terminology is. That's what the diagnosis should be, is it's a substance or medication-induced psychotic disorder if hallucinations are predominant in that scenario. If not, if we go down one more time, which means the hallucinations are not the main clinical predominant issue in the moment, and it doesn't necessarily warrant clinical attention, then we're actually looking at kind of just a basic, which is kind of interesting, just a basic diagnosis of substance intoxication, where there's no hallucinations, there's no disturbance in awareness and in and out of fluctuating like in a state of delirium and disorientation. We just find essentially that this person is intoxicated to some degree and showing effects of a substance. So that's the first little portion with regard to substances. Let's say that there are no substances involved. Let's say we come down here to the next differential diagnostic question, which is there a medical condition involved? If we say yes to that, again, we need to ask ourselves, especially in an instance where there's another state of potential delirium, in and out of awareness, disorientation, some cognitive issues, we actually then, similarly to the one above, we would have a diagnosis of delirium due to another medical condition. Again, this is typically because it's an acute onset, there's disorientation, the person's confused, there's some cognitive issues, and the state of delirium. A lot of the times we're not seeing these things as clinicians because the vast majority of us, probably the majority, are working in outpatient settings or maybe even intensive outpatients. Rarely are we working kind of hands-on in the ER with a physician at the time that the client or patient is presenting with substance issues or a medical condition in the acute scenario. And so, I'll be honest, that's why this state of delirium and these type of issues can be difficult to describe or even put into context because many of us will never likely see any of these issues given the nature of them. Nonetheless, it's good to know where things go and how to chart it out. Let's say that that person isn't necessarily disoriented and going in and out of awareness, that it's not delirium. But let's say there's definitely more severe cognitive decline. Let's say there's definitely executive functioning issues, learning issues, psychomotor or perceptual motor, social cognition issues. That's when we're actually looking at something definitely more serious along the lines of a neurocognitive disorder. And that's where we would head next. So if the person's not acutely onset and disoriented and it's a sudden thing, that's typically delirium. If it's more to where there's this cognitive decline and executive functioning, learning, memory, language, all of that stuff, then we're actually looking at more of a neurocognitive, major, mild neurocognitive disorder. These typically are diagnosed, again, by a physician, a neurologist, someone who would know the exact kind of testing and things that need to be done for a neurocognitive assessment. And finally, if that's not the case, if there's no cognitive and awareness issues, but yet we're going back here to the same presenting symptom, which is hallucinations, if you have a medical condition, but none of these other criteria, the cognitive stuff is not there, then finally the diagnosis would be a psychotic disorder due to another general medical condition. This could be some sort of cerebral vascular sort of accident or brain trauma or tumor or who knows what. There's been some speculation that hyperthyroidism may be a medical condition that may kind of kick people into a state of kind of what I want to say, kind of almost an elevated mood. But in this case, when we're talking about hallucinations, that really necessarily probably wouldn't fit. We're talking probably something more along the lines of some sort of brain trauma or cerebral vascular or something to that effect, some sort of stroke maybe. And certainly a physician would be one responsible for diagnosing that. So this is the first part of the hallucinations dealing with substances and general medical condition. Let's move on to the scenarios that we most likely would see and have to begin to rule out through this diagnostic map. Okay, continuing on. So we've looked at substances, we've gone through the medical conditions. So let's move down the chain here. And the next kind of symptomology that the DSM would have us look at in this particular map is to ask ourselves whether the hallucinations or the hallucinatory experience has intact insight but not accompanied by other psychotic symptoms. So there's no kind of delusional issues, there's no odd or bizarre behaviors, those other psychotic symptoms that we would typically think of. In here, there's intact insight. In this particular mapping, it says usually occurring in several sensory modalities. So, whether it's sight or touch or the senses, smell, those type of things, hearing. And in this case, maybe the person is describing kind of fantastical or childish content, almost pseudo hallucinations. It's almost like an imaginary friend, so to speak, as far as their description of what's occurring. In this case, then, it's saying that the hallucinations are their insight is still intact. There's no other psychotic symptoms, no odd or bizarre behavior or catatonia or any of that, negative symptoms. It's just kind of fantastical and childish. If that's the case, and it has to do more with sensory issues, touch, hearing, typically these things come and deal with, could be occurring after some sort of maybe trauma experience or something to that degree. In this case, if it's a yes, that they have insight still, but there's no really psychotic symptoms, the map here actually says that it may be something of a conversion disorder. So if they're describing something occurring in their body or on their body as far as sensory, but it's more pseudo hallucinations, they can't really pin it down. It doesn't match up with the hallucination descriptions, whether it's, paranoia or odd or anything like that, a conversion disorder would be the most appropriate. And the description for that in the DSM, I'll be honest with you, is really kind of pretty vague as far as what's going on there is with regard to a conversion disorder. So I'd have you refer to that. It can be kind of convoluted with the exact criteria that needs to be achieved. So that, let's say that we get through that and their hallucinations, that their insight is not intact, they do have psychotic features. Let's say that we move down here to where their hallucination experiences are culturally sanctioned. So let's say they're in the midst of either some sort of religious experience or some sort of culture that they're in, that these type of interactions or hallucinations, visions, are part of culturally sanctioned behavior. If the answer is yes to this, the DSM lets us know that that's not considered a mental health disorder. If they're culturally sanctioned, if that's part of what the culture is pretty expected or typical. Going down then, let's say that it's not culturally sanctioned, they're continuing to have hallucinations. And in this case, it's only occurring in the context of an elevated or expansive mood. And in the other video that I made, if it's in the midst of an expansive mood, irritable mood, elevated mood, we know that there's the possibility is there's some sort of mood component. If it's elevated, we know likely that bipolar is involved, which in this case, that's what's happening. Is the appropriate diagnosis would be a manic episode with psychotic features. So we have a mood disorder going on. It's occurring only in the context of the expansive and elevated mood. Then we shift over and that it's a manic episode with psychotic features. If it's not in the context of a elevated mood, and only occurring in the context of a depressed mood episode or diminished interest or pleasure, then we are looking, instead of bipolar, I think it would stand to reason that if it's in the midst of a depressed episode or depressed mood accompanied by depressive symptoms, then we're looking at a major depressive disorder with psychotic features. Or it also suggests that it may be in the context of a bipolar 2 major depressive episode, and that's also something to consider, is that if they've had a hypomanic episode in the past, obviously they've already set in motion the diagnosis of bipolar 2, therefore a bipolar 2 disorder would certainly be appropriate with the idea that they're having hallucinations in the context of a major depressive episode, so within that bipolar 2. So that's kind of a quick little summary of this section, particularly hallucinations in the context of an elevated or expansive or irritable mood, which would be bipolar 1 with psychotic features. Or if we drop down and it's in the midst of a major depressive episode, it would likely be a major depressive episode with psychotic features. Or if they've already had a hypomanic episode before and they've had bipolar, it would be in the midst of a manic depressive episode with psychotic features, or bipolar 2 describing with psychotic features in the case that they're now having a depressive episode in the midst of having bipolar 2. So there you go, clear as mud, right? And let's move on to the next video as we move down the chain. Okay, here's where things really get exciting. Okay, this is where this map really takes a turn. So let's say the hallucinations have been lasting for 1 month or more. So if that's the case, if we say this person's shown up and they've been having hallucinations for at least a month, and it's accompanied by delusions, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms, essentially all of kind of the psychotic symptoms. If that is the case, that they're having also those other psychotic symptoms with hallucinations, If we answer yes to this, then we ask ourselves, the next major thing is to ask ourselves whether or not there's any sort of mood component. Because as we've discussed for several videos, that if there's a component, then we're actually looking at things more in the nature of a bipolar disorder or a major depressive disorder with psychotic symptoms. Or, we're going down the track of some different areas within schizophrenia. In this case, though, let's say that you get to the point of asking yourself, is there a history of major depressive disorder or manic? If you say no to that, then you're actually taking this pathway down to, you're coming to a point where you're looking at a specific time period in order to make a diagnosis. So we're going to leave that pathway there saying, well, there's no history of major depressive or manic disorder, so we're going to follow it down to the time period. But for the sake of this map, let's say that yes, this person has had a history of major depressive disorder and manic episodes. And the next question is, was it during an uninterrupted period of the illness where the psychotic symptoms were concurrent with the mood symptoms? If that's not the case, if there wasn't a concurrent period of time where the mood disorder was concurrent with the psychotic symptoms, then once again you would move over and we'd be looking at the timeline. However, if in fact there was an uninterrupted period where the psychotic symptoms and the mood symptoms were together, and the next step would be during an uninterrupted period of illness where the mood symptoms have been present the minority of the total duration. So this is where this interesting word comes in, present for the minority of the total duration of the active periods. If that answer is yes, that it's only been a minority of the time period, that's when we head over to this next little place on the map here where you ask yourself, okay, so you're going to be having the time question, is whether or not it's been 6 months, at least for those pathways that we've been looking at. If indeed that it's been 6 months, the person hasn't had a history of major depressive or manic episodes, those episodes were not concurrent with the psychotic symptoms, and the mood disorder or the mood periods were not they were a very minority of the total duration, then likely, if that's the case, the likely diagnosis then at that point, if it had been 6 months, would be schizophrenia. If in fact, though, if you follow the yes mapping that we just did, where yes, there was an uninterrupted time of concurrent mood episodes, and there was, the presence, even at a minority of the total duration, there was still some mood components, then we would be looking at more along the lines of a bipolar disorder, which we discussed in the previous video, that we'd be looking at bipolar 1 disorder, or we'd be looking at bipolar 2 disorder as this in this scenario, this mapping as being the diagnosis, especially if they've had or if they're continuing to have hallucinations. Likely it would be with psychotic symptoms. If the person did not have it for 6 months, this is where the map gets a little confusing, as if we bypass this and they didn't have any of these for 6 months, then, as we know, have studied that if it's less than 6 months, it's actually going to be schizophreniform disorder. So anywhere from 30 days, as we know, that's where a brief psychotic episode or disorder is. From 30 days to 6 months, we have a schizophreniform disorder if there's been no kind of overlying or concurrent mood episodes, as we've seen. Schizophreniform. If not, it tells us once again that we'll go along with the other diagnoses of bipolar disorder, along with this schizophreniform. Let's say over here though, let's jump back to this other portion of the map where that there's been no uninterrupted period where the mood has been present for a minority of the total duration. If that's not a yes, then we move down here to asking ourselves whether or not the delusions or hallucinations have been around for 2 weeks in the absence of the mood symptoms, of the manic or depressive mood symptoms during the lifetime course of the illness. So if that person was having concurrent mood episodes and then all of a sudden there's 2 weeks where there's no mood episodes going on, but the hallucinations and delusions continue to happen, if that's the case, that's actually when we go over to the interesting diagnosis of schizoaffective disorder, which I've had multiple clients diagnosed with this disorder, is where they've had periods of time where they've had active hallucinations and delusions, and for a period of time they've had concurrent mood episodes. However, they also have had periods of time where there have been no mood episodes, and yet they continue. There's been at least 2 weeks to where the mood episodes have gone away, and yet the delusions and hallucinations have continued, and that would be schizoaffective disorder. If that's not the case, if the psychotic symptoms are confined specifically to the mood episodes, that's when we're coming back to this concept of it being a bipolar disorder or a major depressive disorder with psychotic features. So that ultimately is what we get down to, is that if there's been no period of time where the mood episodes have not been present, then we get down to the bottom to where it's usually a bipolar episode or a major depressive episode with psychotic features, rather than, for example, schizophreniform or schizoaffective or even schizophrenia. There's been no significant mood episodes occurring at that point. So that is this map right here. And let's continue on to the last one. Okay, here we are on the last map. This is where in the previous video or in the previous clip there, the hallucinations had lasted more than 1 month, which led us down these other pathways of it likely being either schizophrenia, schizophreniform, or schizoaffective disorder. This one says that, or this little map here asks us if it's been at least 1 day and less than 1 month, then we are actually moving over towards a brief psychotic disorder because of the period of time. If we answer no to this, then if the hallucinations are not covered by clinically significant distress or impairment, then the map would have us do other specified schizophrenia spectrum or other psychotic disorders. So this is kind of what they call kind of almost a wastebasket diagnosis, where they're having hallucinations, but you cannot pin it down to any other, that it's not covered by any of the other diagnoses that you've seen. Then it's another specified schizophrenia spectrum disorder. That would pretty much mean that you really are lost at what to even, or where to even go. And then finally there's a no that says, well, if they are having hallucinations, they're non-pathological. So that's kind of an interesting way to end this map, is the American Psychiatric Association pretty much says, well, they're having hallucinations, it's not causing clinical significant impairment or distress, they're just kind of having hallucinations and they're non-pathological, then I guess that's what we're going to call it. This other part of the map that came down from the other, the previous little video segment, is similarly in this instance that there is the hallucinations present. It's coming down from where we talked about all the mood, with them having some sort of mood episodes and then finally getting to the point where there's no episodes of mood, then the response would end up being that it's another specified schizophrenia, spectrum disorder, or psychotic disorder, if that's the case. So similar to what we just went through down here, is that you went through all the time frames that it had lasted at least 6 months, or even between 1 month and 6 months, and there's really no mood episodes, but it's causing clinically significant distress. This would be almost along the lines as this one down here that we just covered, that it ends up being another specified schizophrenia spectrum, again, or other psychotic disorder. Again, almost what they call wastebasket. You just can't quite find any sort of category to throw it in. So you're diagnosing it as something, but in this case, insurance or any other entity is not going to pay for something that's otherwise specified, that you can't even exactly tell what it is, and they're not going to pay you to treat it if you can't classify it for what it is. So that is the hallucinations pathways. There's a lot of zigzags. The key thing to remember in the end is asking yourself about the mood component. That seems to be kind of the time frame in the mood component. If mood is the heavy or major component of what's happening during the course of the hallucinations, then you really need to ask yourself whether or not it's a bipolar kind of psychotic episode, or a major depressive kind of psychotic episode, or is there more of a schizoaffective where mood is present and then it's not, but the hallucinations continue. And yet, if there's no mood at all, and there never has been, but the hallucinations continue, then it would be more of the classic schizophrenia. So this is kind of a good one to chart and look at. And yet, if you just kind of ask yourselves those main questions about mood and time frame, that'll help you sort this whole hallucinations symptomology a lot quicker and easier. Okay, there we go. That is the hallucinations DSM diagnostic map.